Hello and good morning friends. Today we are going to discuss about the recent changes in the guidelines of the COPD management according to the GOLD criteria. So these are basically the GOLD 2023 guidelines which have been recently published, and let's jump into the topic right now. So first of all, there are some key definitions that has been introduced in the GOLD 2023 guidelines. These are the GOLD 2023 guidelines. The first term which has been introduced is pre-COPD. So what is the pre-COPD? Those individuals who have some respiratory symptoms with the structural lung lesions like emphysema and having the physiological abnormalities which include, for example, low FEV1, or they have gas trapping, or they have hyperinflation of the lungs, or the reduced diffusion capacity of the lungs, or there is the rapid FEV1 decline, but there is no obstruction. That means the FEV1 by FEVC, that is forced expiratory volume in the first second by the forced vital capacity, is more than or equal to 0.7. These kind of patients have been termed as pre-COPD patients, right? So the pre-COPD are those patients who have some structural changes in the lungs like emphysema or decreased FEV1, gas trapping, hyperinflation, decreased diffusion capacity, or the rapid FEV1 decline. But the basic requirement is that the FEV1 by FVC ratio should have to be greater than or equal to 0.7. These kind of patients have been termed as pre-COPD patients, right? Now the next definition they have introduced is about PRISM. So what is the PRISM? PRISM is the preserved ratio and impaired spirometry. The ratio is preserved but the spirometry is impaired. It is to identify those with the normal ratio but abnormal spirometry. These subjects who are pre-COPD or the PRISM patients, these both kind of patients can eventually lead to COPD, but not all of them. Some can revert back. There is a provision of reversion. That means the core definition of the COPD, that is the non-reversibility, is not followed in the PRISM and pre-COPD patients. Now jumping to the next changes, what we have noticed in this is about the we can see about the bronchodilation part. How to diagnose the patients of COPD? The main component from differentiating it from the bronchial asthma is to measure the FEV1 after giving the bronchodilator. So how the bronchodilator is being given? The bronchodilator here which is used is generally, what we generally use is short acting beta agonist, or we can use short acting anticholinergics. Right? So if we are using any short acting beta 2 agonist, we have to use it 400 micrograms, and short acting anticholinergics has to be used 160 micrograms. And after using this, we have to wait for around 15 minutes. After that we have to do the PFT again, and for this we have to wait at least 30 to 45 minutes. After that the PFT is done, right? So this is the method of bronchodilation reversibility test what we can use. Next is the same old criteria for uh, grading the patients according to the gold grades, the severity of the airflow, like gold 1, 2, 3 and 4. Mild, moderate, severe and very severe. So if the FEV1 here is more than or equal to 80% of the predicted value, here between 50 to 80%, here 30 to 50%, and last is less than 30%. If the FEV1 is less than 30%, it is termed as a very severe category of the gold criteria. The MMRC grades are the same. We all know that what the MMRC grades are. We do not have to mention that is grade 1 to 4. We all know that. Now the major change what we have come across is I'll keep this slide in the loop just a second. So previously we were using what? The gold criteria for management. We were using the criteria of A, B, C, D, categorizing the patients in the 4 categories. But now what we are doing is we are categorizing the patient in 3 categories only, and that too like A, B and E. A, B and E, right? There are only 3 categories now. C and D have been merged into E, right? And if on x-axis and the y-axis, if we are drawing on the x-axis the symptoms part, like if the symptoms part, and on the y-axis the severity part, right? If on the severity we are facing that more than 2 exacerbations or more than 1 hospitalization, then it is the severe category, or 0 to 1 moderate exacerbations and 0 hospitalization is in the mild severity, right? And for the symptom part, we can use the MMRC scale, that is MMRC 0 to 1, and here the MMRC of 2 or more, or we can use the CAT score of less than 10, or here more than or equal to 10. So now what we see is, once we have established, first what we have to do is we have to establish spirometrically. Of course we can only establish the diagnosis of COPD with the help of the spirometry. Once by the spirometry we have diagnosed the patient is of COPD, and then we have to assess the airflow obstruction. Airflow obstruction has to be estimated. Airflow obstruction has to be estimated, which is done by the gold categories 1 to 4. Then after doing that, we have to assess the symptoms and the risk, that is according to this A, B and E. Here the A, B, E, what are they? These are just nothing but exacerbations 0 to 2 or the more than 1 hospitalization or the 0 hospitalization. So now we can easily plot the patients in 3 categories A, B and E, right? The C and D have been merged here, right? Next, and the management depends on them, right? We'll discuss management shortly. So one additional key points are that what we have to advise further. For example, some vaccinations have been advised. Vaccinations in COPD patients like influenza vaccine, pneumococcal vaccine, and like Tdap vaccination, Tdap vaccination, that is diphtheria, pertussis and tetanus vaccines. We can advise the shingles vaccine, right? So these kind of vaccines have been recommended in the 2023 guidelines, and also the option for the LTOT, that is long term oxygen therapy at the home. In home we have to advise the long term oxygen therapy for those patients in whom the PaO2 is less than or equal to 55 mm of mercury, or if it is less than 60 mmHg with cor pulmonale. With cor pulmonale or secondary polycythemia, right? So in the patients, those who require long-term oxygen therapy, the guidelines are straightforward now. That is, in those patients, if the partial pressure of the oxygen is less than 55 mm of mercury or equal to 55, or if the patient is of cor pulmonale or secondary polycythemia, the cutoff has been increased up to 60 mm of Hg, right? These are the basic guidelines. Now, as far as the pneumococcal vaccine is concerned, there are the guidelines that the patients can take the polyvalent vaccine 20 straightforward, or they can take first PCV 15, which is followed by PCV 23, right? Okay, now let us jump into the therapy part, that is how to use the therapy and what are the management protocols, what have been changed there. So since we are dealing with this kind of table in previously also, apart from that, from the E category there are the C and D over there, nothing much has changed. For the patients with category of A, bronchodilator, that is short acting bronchodilator, can be used, right? If the patient lies in B, LABA plus LAMA, that is long acting beta agonist or the long acting muscarinic antagonist, can be used, right? And in the patients of category E, sorry, it is not C but E, we can use LABA plus LAMA, and inhaled corticosteroid can be added plus or minus. If plus means if we have to count the eosinophil levels. If the eosinophils are more than equal to 300, we have to add ICS, or if it is not, then no need to add the ICS, and it depends upon the symptoms. Now, if the there is eosinophils are less than 300, we will not add ICS. But if in case the patient is having the exacerbations, right, and if there is, suppose patient is having exacerbations, and we do the blood eosinophil levels, if it comes out to be more than 100 at that time, then we can use ICS, right? But at the time of exacerbations also, we can choose to go with roflumilast, that is phosphodiesterase 4 inhibitor, in the patients with the FEV1 less than 50% and chronic bronchitis patients, we can use the roflumilast. And we can also add a macrolide like azithromycin. Most commonly it is used in the smokers, right? So this is the primarily change which has been introduced in 2023 guidelines. I think these are helpful to you, and please comment if there is something you find additional point which can be added, or some suggestions, queries. These all are most welcome. But the last point is that when to add the ICS, it is still, I think, some controversy is there. So let me clear it off. Inhaled corticosteroids, right? Inhaled corticosteroids is used only in, there are three kinds of recommendations, right? Like first is where it is strongly recommended. So it is strongly recommended in those patients who have exacerbations, as we have discussed, or the history of hospitalizations, right? Or there are 2 or more exacerbations per year, that is severe category, or the blood eosinophils are more than 300, or there is a history of concomitant asthma, right? That is overlap syndrome. So if these categories are there, ICS is strongly recommended here. Now also there is a category which favors the use of ICS, and these are if there is one one or more moderate exacerbations per year, right? And if the blood eosinophils are 100 to 300, right? So what we have discussed here is that in category A, short acting beta agonist is used. In category 2, short acting or long acting also we can use, right? LABA or the LAMA can be used. In the category B, the LABA plus LAMA has to be used. In category E, LABA plus LAMA, of course it has to be used. It can be supplemented with inhaled corticosteroids if the eosinophil count is more than 300, and it is strongly recommended that ICS is strongly recommended when there are the exacerbations or the hospitalizations, or there are more than 2 exacerbations per year, or the blood eosinophils are more than 300, what we have discussed, and if there is a concomitant asthma also prevalent in the patients, right? And it is favored also in the patients having the blood eosinophils 100 to 300. That means we can use ICS in the patients of having blood eosinophils more than 100, depending on the condition of the patient, right? Now, what strongly against the use of ICS, that means in these patients we should not have to use, is if the patients have repeated pneumonia events, right? If he has the repeated pneumonia, if the eosinophil are less than 100, and if there is any evidence of mycobacterium infection, right? In these kind of patients, of course, we know that the mycobacterial infections generally we do not use the corticosteroids. So these are the 3 requisites where we should not have to use the inhaled corticosteroids. Okay. Now to summarize the latest gold criteria changes in 2023, we will summarize that in just 1 minute. Like there are the new terms like pre-COPD, PRISM. These pre-COPD and the PRISM do not lie in the category of the COPD, but these kind of patients can present as COPD in the future years, coming up to 5 years, but they can revert back also. For the bronchodilation, we can use short-acting beta agonist or the short-acting anticholinergics in the dose we have discussed. Now, once we have diagnosed the patient as a COPD by spirometry, then we have to follow we have to categorize the patient according to the gold severity criteria, that is mild, moderate, severe, very severe. After that, we have to categorize the patient according to the severity and the symptoms according in the categories of A, B and E, in the A, B or E. So after categorizing, and E is nothing but the combination of the C and D of the previous criteria, right? And what additional features are there? We have to vaccinate these kind of patients, like vaccination with the influenza, the pneumococcal, Tdap and the shingles vaccine. The long-term oxygen therapy is required in the patients who are having the partial pressure of the oxygen less than 55 mm of mercury or less than 60 mm of mercury with the cor pulmonale or the secondary polycythemia, right? And for the treatment part, when the patient is of category A, we have to use beta agonist, straightforward. It may be the short acting or the long acting. In the category B, the LABA and the LAMA are added, and in category E, the LABA, LAMA plus minus ICS according to the eosinophil count and the exacerbations. And if the exacerbations are there and the patient is not controlled, we can add the roflumilast, which is a phosphodiesterase 4 inhibitor, where the patient is having the forced expiratory volume in the first second less than 50% and the chronic bronchitis, and we can add the macrolide like azithromycin, most commonly in the smoker patients. For the ICS, there are the strong recommendations in the patients having the exacerbations or the hospitalizations or more than 2 exacerbations per year, and the blood eosinophil more than 300, and the history of the concomitant asthma is there. And ICS is favored in the patients who are having more than 1 moderate exacerbation per year, blood eosinophil 100 to 300, and against is repeated pneumonia, eosinophils, and the mycobacterial infection. I hope this all thing helped you And in case it helped you in any kind, please hit the like button and subscribe to my channel, and please let me know what other topic we can discuss over here. Thank you for the patient hearing.